All right. Good morning. Welcome to the Unitarian Universalist Church of Ogden. I'm Dylan Zwick, and I'm the worship lead today. Please put your phones on silent, but feel free to take pictures of the service and to post what you hear and see online. Send the message to the broader community. If you're new here today, welcome. Thanks for coming. Fill out a visitor card in the pews and put it in the offering basket when it comes by later. And please stay and chat with us after the service. The UU Church is an open, tolerant place where diversity of thought is encouraged, sought, and appreciated. It doesn't matter who you love or how you identify yourself. We come here because we want to think for ourselves, ask questions, value the exchange of ideas, hear from others, and be challenged. There are a range of beliefs among those here. Generally, though, we believe in caring for the planet and caring for one another. We are a lay-led ministry, which means the messages come from everyone here. Accordingly, the presence of each and every one of you adds to the atmosphere, and we're glad you're here. All right, so first, an announcement, probably a very big announcement. So we are in very advanced talks regarding a part-time minister to work with us over the next year, and this will likely be starting next week. So her name is Kristen Famula, and she most recently served as interim DRE at the First Unitarian Church of Albuquerque. Now, a few things. Kristen lives in Truckee, California, and would be working for us remotely. She'd be leading about a third of our worship services, helping us relaunch an RE program, and assisting us as we search for a full-time minister again this year. Kristen will probably be joining us in person here on October 15th. Much more info to come, but just wanted to let you know that looks like that's probably going to happen. So that's exciting. Our chalice lighting words this morning are from the Reverend Dr. David Breeden. Welcome, all, to this place of love and justice, this place where we attempt to live up to humanity's highest ideals and highest hopes. Do we fail? Yes, we do, often. Do we try again? Yes, we do, always. Welcome all to this place of love and justice, to this gathering where the sacred and the holy are our being together. Now to light our chalice. Debbie will light the chalice for us today. And all, please join with us in lighting our chalice by saying the chalice lighting words found in your order of service and displayed upon the screen. We light this chalice for the warmth of love, for the light of truth, and for the energy of action. Thank you, Debbie. All right, our opening hymn is switched out. It's different from 1017, which I think is in the order of service. We will be singing 121, We'll Build a Land, in your hardback hymnal. Sisters and brothers, anointed by God, may In the United States, we spend more money per capita on healthcare than any other nation in the world. We spend twice as much per capita as the United Kingdom, where they have the NHS, a universal single-payer healthcare system. About half the money the United States spends comes from taxes. In other words, the United States spends as much, a little more actually, per capita in tax dollars than the United Kingdom, and in exchange for this, we do not have universal health care. So, what are we getting for all this money? Well, by any standard health metric like longevity, we're not doing any better than other first world countries. So we spend twice as much on healthcare as the UK, as much per capita in taxes as the UK, and yet we don't have universal coverage and aren't as healthy. Clearly, this system isn't working very well and could be significantly improved. Our opening reading today is a section from a New York Times opinion essay published on July 18th of this year. Written by Dr. Liren Ivan, a professor of economics at Stanford, and Dr. Amy Finkelstein, a professor of economics at MIT. It's titled, "We're Already Paying for Universal Health Care. Why Don't We Have It?" The only solution is universal coverage that is automatic, free, and basic. Automatic, because when we require people to sign up, not all of them do. The experience with the health insurance mandate under the Affordable Care Act makes that clear. Coverage needs to be free at the point of care. No co-pays or deductibles, because leaving patients on the hook for large medical costs is contrary to the purpose of insurance. A natural rejoinder is to go for small co-pays, a $5 copay for prescription drugs or $20 for a doctor visit, so that patients make more judicious choices about when to see a healthcare professional. Economists have preached the virtues of this approach for generations. But it turns out there's an important practical wrinkle with asking patients to pay even a very small amount for some of their universally covered care. There will always be people who can't manage even modest copays. Britain, for example, introduced copays for prescription drugs, but then also created programs to cover those copays for most patients: elderly and young people, students, veterans, and those who are pregnant, low income, or suffering from certain diseases. All told, about 90% of prescriptions are exempted from the copays and dispensed free. The net result has been to add hassles for patients and administrative costs for the government, with little impact on the patient's share of total healthcare costs or total national healthcare funding. Finally, coverage must be basic because we are bound by the social contract to provide essential medical care, not a high-end experience. Those who can afford and want to can purchase supplemental coverage in a well-functioning market. Here, an analogy to airline travel may be useful. The main function of an airplane is to move its passengers from point A to point B. Almost everyone would prefer more legroom, unlimited checked bags, free food, and high-speed internet. Those who have the money and want to do so can upgrade to business class. But if our social contract were to make sure everyone could fly from A to B, a budget airline would suffice. Anyone who's traveled on the low-cost airlines that have transformed airline markets in Europe knows it's not a wonderful experience. But they do get you to your destination. Keeping universal coverage basic will keep the cost to the taxpayer down as well. It's true that as a share of its economy, the United States spends about twice as much on health care as other high-income countries. But in most other wealthy countries, this care is primarily financed by taxes, whereas only about half of US healthcare spending is financed by taxes. For those of you following the math, half of twice as much is, well, the same amount of taxpayer-financed spending on healthcare as a share of the economy. In other words, US taxes are already paying for the cost of universal basic coverage. Americans are just not getting it. They could be. We arrived at this proposal by using the approach that comes naturally to us from our economics training. We first defined the objective, namely the problem we are trying but failing to solve with our current US health policy. Then we considered how best to achieve that goal. Nonetheless, once we did this, we were struck and humbled by the realization that at a high level, the key elements of our proposal are ones that every other high-income country and all but a few Canadian provinces has embraced. Guaranteed basic coverage and the option for people to purchase upgrades. The lack of universal health insurance may be exceptional in the US. The fix, it turns out, is not. All right. Our guest speaker today is my friend and neighbor, David Lesser. Dave is a medical doctor with a degree from the Air Force Academy who served in the Air Force for 26 years before moving to Ogden in 1999. He's now the treasurer of Common Sense Healthcare for Utah, and one of his motivations for being involved with Common Sense is seeing the difference in the incentives and motivations between the Air Force, which provides universal care, and private practice here in Ogden. Dave is also the husband of Dr. Rosemary Lesser, the state representative for District 10, and the only Democrat in the Utah legislature outside of Salt Lake County. Common Sense Healthcare for Utah is a citizen-led ballot initiative that would implement a single-payer healthcare system with universal coverage in the state of Utah. They aim to be on the 2026 ballot. An ambitious goal, to be sure, which Dave is here to tell us more about and to answer some of our questions. All right, Dave, thank you for joining us. And the pulpit is yours.
Thank you. Let's see.
You look so much younger in person.
That's an old photo. Does that work? Well, thank you. Dylan, thank you very much for the introduction. Did this get cut? Oh, I guess not. The reading from Amy Finkelstein's article is a perfect lead into our proposal. So, you know, as a lapsed Catholic, I wasn't really quite sure what to expect from a Unitarian service. So I did what most people would do, and I consulted ChatGPT. And let's see if I can figure out how to advance this slide. So I always think it's a good idea to start off with humor. So I said, whoops, it's not sharing here, Dylan, let's see. Let's go back to this.
It's still on. So if you go down to your images right there.
Oh, okay.
Yeah, if you bring that. Okay, so it's just, you have a set of images?
Yeah, I'll just go to this one.
Okay, perfect.
So here's what I asked ChatGPT. I said, write a joke for Unitarians about healthcare. And they said, why don't they argue about it? Because they believe in universal care. I think ChatGPT still needs some work. But let me go a little further to define the current problem as we see it. This shows graphically the current situation with healthcare costs in the world. The US is paying over $12,000 a year per person per year. And the average for the rest of the first world countries is less than 6,000. So just like Dylan mentioned, we're paying twice as much. So what are we getting for it? Our outcomes are actually significantly worse than the rest of the world. So if you look at the top, this is higher performing versus lower performing. We have fallen off the cliff. And this graph is from measurements like maternal mortality, lifespan, various other measures of access to healthcare. One of the significant problems is this. So the line at the bottom shows the rates of inflation and wage growth since 1999. And the yellow lines at the top are the cost share of healthcare that's being pushed to individuals. So this is increasing deductibles and copays. So not only is healthcare more expensive per person, it's more expensive for each individual that's not covered by insurance. And this slide gets to the basic problem. The red line at the bottom shows the growth since 1970 of people who provide healthcare. This is people who take care of patients, people who actually involved in healthcare. The blue line shows the growth of people who make a buck off the healthcare system but don't provide healthcare. And this is administrative costs, this is profits to shareholders, this is executive salaries for insurance companies. So that's the basic problem that we have. That's where all that difference in the money between what other countries are paying per capita and what we're paying is it's not being used to provide healthcare. And that's what we think is wrong. So our organization formed about 1.5 years ago. We organized as a 501c4. And one of the first things that we did, first of all, we're made up of a group of doctors, some business owners, and some other community activists. One of the first things that we did was did a survey of people in Utah to find out, what do people really think about it? And you can see here that the vast majority of people, and we were surprised by this finding in conservative Utah, the vast majority of people felt that healthcare is essentially a human right and that they would vote for the potential to have something on the ballot in 2026 to create that. Now, we were taken aback by that, but we were also encouraged and decided, based on those results to sort of continue to work on this. So one of the first things we did, we commissioned Dr. Gerald Friedman, who's a Harvard-trained health economist who currently is at University of Massachusetts. He spent about 3 months doing an extensive analysis of all of the healthcare expenditures and revenues in Utah. And he's recently, just a couple weeks ago, we got his 46-page, heavily footnoted report that looks at all the ins and outs of healthcare spending in Utah. And one of the things that he found is that, like Dylan said, 50% nationally, but in Utah, close to 70% of healthcare expenditures are already federal tax dollars. So that means Medicare, Medicaid, TRICARE, which is the military's healthcare system, the Veterans Administration, and CHIP. Those are all federal tax dollars that we're already paying for. What most people don't recognize is that private insurance is heavily subsidized by the federal government. When a business owner pays for his employees' healthcare premiums, that business owner deducts that from their business taxes. And so that's essentially federal money that is being applied to subsidize private health insurance. So that's probably, his analysis of that accounts for part of the difference between Amy Finkelstein's 50% and his analysis of 70% in Utah. So sort of the bottom line from his analysis was that relief from the administrative burden, from getting rid of some of that blue line on that previous slide, would save $14 billion in healthcare expenses over the next decade in Utah. It would also, we would be able to eliminate the financial barriers. And like Dylan said, even first dollar barriers to healthcare cost some people. But by eliminating that, he shows that we would not only increase health, but we'd also increase productivity and also help the economy. And the mechanism for doing that, the money has to come from somewhere, would be a payroll premium similar to a Social Security premium, which would be used to finance this. That payroll premium would replace all private insurance policies, it would replace all deductibles and all copays. And that payroll premium would allow first dollar coverage for everyone in Utah. There's enough, with his analysis, there's enough money in the system to provide that. Our basic premise is that the market forces that make the American economy strong aren't appropriate for healthcare. To have that kind of a market-driven enterprise, you have to have equal partners on both sides of the transaction. No one ever went to get an appendectomy on a Good Friday sale. Nobody gets healthcare when they don't need it because it's on sale. And if you do need an appendectomy, you're going to pay whatever it costs. So you don't have an arm's length, even partner transaction when you're dealing with the healthcare system. We believe that the healthcare system should be patient-focused and not profit-focused. So the overhead for the private for-profit insurance industry in Utah is about 20%. And that consists of administrative cost. A lot of that consists of the efforts to evaluate pre-approval, evaluate denial of care. When I was in practice in Ogden, we had between 5 and 7 docs in our practice. We employed 3 people full-time who all they did every day, all day, was talk to insurance companies. And on the other end of that phone line, there was 3 people who were talking to them. And all that was to negotiate things that actually shouldn't even had to be negotiated. It was care that was medically indicated but needed to be argued about whether or not it was going to be obtained. All of those administrative roles would go away. So like I said, the private insurance has an overhead of around 20% in Utah. There's a company called PEHP. I don't know if any of you have been state employees, but PEHP covers the people who are employed by the state of Utah. Their overhead is under 4%. They don't have to have marketing expenses. They don't have to advertise. They have a set schedule of covered services, so they don't have to have people to argue about what the covered services are. And their overhead is around 4%. So in combination with increasing the revenue with a payroll premium and decreasing the overhead from 20% in private to 4%, that's where enough money comes from to essentially cover everyone from Utah. Now, PHP currently covers around 200,000 people, and our goal would be to sort of use that, use their relationships and their ongoing business model to essentially upscale to cover the whole state. This doesn't solve all the problems. We still have to control costs. Pharmaceuticals being a significant part, hospital costs, and physician salaries. We've actually had buy-in from physicians who have told us, in fact, there was a resolution at the Utah Medical Association House of Delegates recently endorsing this plan. Physicians recognize that they may take a small cut in their pay, but they also are going to have a cut in their overhead because they're not going to have to employ those 3 people that are are just part of the administrative burden. It would also simplify the claims process. Instead of having to negotiate with 5 or 6 or 7 different insurance companies, there's one form to fill out. It's very easy to not have to worry about different requirements for different insurance companies. Pharmaceuticals are our problem, and we don't know for sure whether 3.5 million people would be a large enough pool to be able to negotiate significantly with pharmaceutical companies. We're still investigating that. But the fact that Medicare finally has been given the approval to do that sort of gets the ball rolling, and I think that we would be able to sort of follow on their coattails. What we've done now is, having finished the survey, having finished the economic analysis by Dr. Friedman, our next is to do much more extensive polling of individuals, of business owners, and of physicians to find out just what people in Utah want. We don't want this to be a top-down proposal. We want this to reflect the needs of the people of Utah. And so that's our next step. And our next step is to hire health policy experts, polling people, and attorneys to start moving this process along. Some ways that you can help. First of all, you can share your story. We passed out the little cards that, I think I have one here. The QR code here goes to our website, and there's a place there where you can submit your story. Dry policy doesn't often move legislation very well, but people's personal stories does. And we've collected several dozen stories from people who have submitted on the website. You can do it anonymously, or you can use your name. You can do it written, you can do a video. We have a few people who have done videos on the website to tell the stories about the problems that they've had with health insurance. So sharing your story helps. Spreading the word. Dylan, he finally got tired of hearing me talk about this so much, so he invited me to come here. But if you'll tell the same thing among your family and friends, we're happy to come talk to any groups that might be interested. You can volunteer. Again, if you go to the website, there's a place to volunteer. Even if you just get your name on the mailing list, we send out something maybe twice a month, and we won't spam you and give other information, but we try to keep people up to date with what's going on. And there's also a button on the website where you can donate to help us with the next step, which is hiring the people that are, they're going to help us to get this enacted. We are mostly, like I said, physicians, some business owners, and some other activists. We're going to be out of our depth pretty soon. We need to hire national level health policy experts to make this happen. And, Medicare for all nationally is a dead issue for the foreseeable future. But just like, women's suffrage, same-sex marriage, many of those kinds of things happen initially at the state level. And then, the dominoes start to fall. And we're hoping that Utah could be one of those dominoes. People say, well, why would Utah, conservative Utah, be a good place to have this happen? Well, a couple of advantages we have. We are a relatively young and healthy state, so we don't have the chronic health expenditures that, say, Mississippi has. At 3.5 million people, it's a relatively small state with somewhat limited diversity, so we can make things that cover people, we can make policies that will cover people here fairly uniformly. The other thing is that because of Primary Children's and Huntsman Cancer Institute, we're a referral center for Wyoming and Montana, and still there? Yeah. So we have referral center for Wyoming, Montana, Idaho. So there's out-of-state money that comes into this state all the time, and it sort of makes a floor of revenue that we can always count on. So we only have to fill in the gap. There are questions about what's this going to cover? Is this going to be a Cadillac program or a Volkswagen program? And that's going to depend somewhat on the input that we get from individuals. The amount of the premiums are going to depend on things, whether adult dental is covered, whether long-term care is covered. Those are all details that need to be worked out, but this is the basic concept. So one of the reasons that I wanted to have the opportunity to talk with you is because we want to hear also feedback from you and questions. And the more we get challenged about our assumptions, the more likely we are to be successful once we finally get this program on the ballot. So please, if you have any questions, I'd love to hear those. Yes, sir.
I'm a primary care doc for 35 years, just background on me, so that's
Yep.
where I'm coming from, and have witnessed the inequities, up close and personal for decades of our system and the inefficiencies. So you referenced, the 3.5 million population as being, a liability, and yet, we all know Utah likes to go it alone. Utah likes to develop the Utah way.
Right.
That's very, very popular. I'm sure will make this more palatable to a lot of conservatives and policymakers in Utah. But would there be some advantages to a consortium of states when you're looking, or does that begin to make this wonky beyond belief and unwieldy in your estimation?
Well,
it seems like there are other states in the Intermountain West with whom we could partner.
Sure. I mean, there are definitely other states who are trying to do individual things like this. Colorado, Washington, Oregon, Wisconsin, even New York. We're trying to learn from the experiences of those. Like Washington failed to get enough signatures to get theirs on the ballot. Colorado had a few other issues. So we're interacting with and trying to learn from their issues. But I think that this needs to be, it's hard enough just to do it as a single state focused thing. And so that would be our goal. Yes. Go ahead, Bill.
Is Medicare and Medicaid, the way it is designed and administered, a model for this expansion idea, or would this be substantially different?
Medicare is probably a reasonable model for it. And Medicare and PHP are similar. They both have overheads around 4 to 5%, and they both basically have a set of benefits that are universally accepted to be okay. And so they both, you don't have to ever argue with Medicare about whether something's going to be covered or not. When I was in practice, I had a large Medicare population, and when I submitted an insurance claim to a private insurer, I was usually going to get paid more than the claim that I submitted to Medicare. But my Medicare claims came in a check electronically next Tuesday, and my private insurance claims came in 2 months, 3 months, 6 months later, after the employed person that I had in my office had argued with them for a while. So it's a trade-off. But yes, a Medicare type administration would be, and actually PHP and Medicare are fairly similar in the way they work. Yes.
So have you started to think of your strategies for overcoming the private insurance and HMO lobbies?
Yeah,
those suckers are gonna fight hard against
there's no question that this is an existential threat to the private insurance industry, and there will be national interest in making sure that this domino doesn't fall. We have no illusions that that's not going to be the case. When we first started this, I was thinking a ballot initiative as a way to enact legislation, and it's really not. It's a way to essentially raise public awareness and get people on your side and educate people. And I think that if we can do that, then the popular demand will be for something like this. I mean, most people think their insurance is okay until they need to use it. And that's when people find out how bad it is. And that's why stories are helpful, because it's hard to convince. It would be hard to convince people to do another payroll deduction unless they realize that they're going to be better off. Now, just like everything else, there will be winners and losers with this, depending on where you are socioeconomically. There will be some people who'll be better off. In fact, the majority will, but a few people won't do as well. We know that if we eliminate first dollar coverage, utilization is going to go up somewhere between 5 and 8%. Well, it's going to go up primarily amongst the group of people who've been barred from getting care previously. And so if the capacity doesn't change, the people who've had easy access to care may find, at least temporarily, that they'll have a harder time because all of the people who couldn't get in before now can. And so, we want to make sure that we're not substituting one set of inequities for another set of inequities. And so that's why we really need, national level health policy experts to help us with this. And we need to listen to people like this group and to figure out, what's going to be acceptable to people. Yes.
So have your group thought of any incentives that you might present to that FAT administration section to give up their livelihood and their jobs and go along with this?
There are not any incentives to offer them. This is definitely a threat to that industry. And if PHP expands from 200,000 to 3.5 million, they're going to have to hire some people to help do that. And hopefully the people that used to work for Blue Cross will come over. Sir.
I'm sort of a dual citizen. I spend time here and in California. And what I found is I saw my high school physical doctor, and then when I turned 65, I started seeing doctors locally. And now in California, you don't want to see a doctor. There are so many people backed up and waiting. Your wait time is forever in a week. And are you thinking about anything going that direction, or can I take it that direction? Or
Yeah.
Because it's for my wife and I, it's a challenge.
Yep. Those are all things that, there's no easy answer to that. Like I said, if access is increased, utilization, if utilization is increased because of easier access, there's no doubt that at least until things equilibrium is reached again, that there may be things like longer waits, and that's going to be something we're going to have to probably deal with. On the other hand, we have to really recognize that, and this involves really a cultural change in the U.S. It's not just a change in medical policy, but it's a cultural change about expectations and outcomes. The problem is that we're not doing well now. We have the highest cost and the worst outcomes, and we're approaching 20% of GDP. 20% of GDP that doesn't do anything except keep us going. It doesn't make anything, and we don't. There's no if we're having to live on the other 80% of GDP to compete with the rest of the world, to have healthcare costs be 20%. It's a loss, of all that. So what we're doing and healthcare costs are continuing to rise, and as they start to exceed 20%, the system's going to collapse, and it's either going to collapse into chaos, or we're going to have some sort of a plan like this, or like something similar to this, ready to go. And so we can't continue what we're doing now. And this is one avenue that we hope to try to make some progress with. Tim.
So in Dylan's introduction, that article kind of likened this coverage to riding on a budget airline. So does that mean, under this system, would you need supplemental coverage to get, coverage for rare diseases?
Yeah.
Or something like that?
So Dr. Friedman and Dr. Finkelstein have some disagreement about how we should do this. And there's one school of thought says, Australia basically has, they call it Medicare for all in Australia, and everybody is covered with basic services, and everybody can buy supplemental insurance. You could buy maternity coverage. Well, most of us probably wouldn't want to buy maternity coverage, but you can buy cancer coverage. You can buy other kinds of coverage if you need it and can afford it over and above the basic care. We would try to actually have a little higher level of basic care, and we think we can afford that with the payroll premium, but we have to figure out how to balance what's an acceptable premium versus what's an acceptable level of care.
Doesn't that create a two-tier system? haves can get this fancy coverage.
Well, I mean, right now we have a two-tiered system. You know, I mean, basically, other countries, you know, like Canada specifically, triages by having wait times. We're triaging by not having affordable access. It's triage one way or the other. And we think that our triage is the least fair because the people who are most vulnerable are the people who are being triaged out. Yes.
Yeah, and we're being triaged out even when we are working. Like I work for Ogden City School District, which is not some big corporate evil entity, but I'm kept on 5 hours and 54 minutes a day. So those 6 minutes I don't work means I don't get health insurance. And I'm one of many employees that they employ this way, so they don't have to give us health coverage, but earn too much to qualify for Medicaid.
Yep.
So we work from getting no health coverage.
Yep. And that's you're the kind of person that this would help. This isn't going to help Medicaid people. They're already on Medicaid. They're already covered. This is going to help working people. This is going to help people with insurance, but who couldn't afford, who don't, you know, people who have insurance with a $10,000 deductible don't go to the doctor because they might as well not even have insurance. So, you know, the idea of having access without those deductible costs makes people healthier. You know, the person who doesn't get a $100 screening test and ends up paying $100,000 to cancer to treat the condition that they would have been able to prevent it if they gotten the screening test. That's a drain on the economy, and that's part of what Dr. Friedman's analysis shows is that, you know, by eliminating first dollar barriers and getting more preventative care done, it's cheaper and it's better care. People are healthier and more productive. You know, we're getting interesting, you know, first of all, legislation in Utah never passes based on altruistic or moralistic things. It has to be based on economics. And so our goal is to try to get businesses to be the ones who are behind this. That's the only way we're going to get this passed. And there is some variability on businesses' enthusiasm about it. Most small businesses are very enthusiastic because they don't have the leverage to negotiate reasonable contracts with insurance companies. We would be an economical alternative for them. There are other businesses, though, that use healthcare as a leverage to keep their employees captive and keep them from moving on. And, you know, they're not going to be as supportive about this as others will be. So again, we're trying to navigate this set of bad outcomes and avoid other bad outcomes. But it's a very complex problem. There's no question about it. And I think we'll be lucky if we're ready to do this in 2026. It's a lot to do. Yes, sir.
The other day I heard on NPR a story about bill collectors sending these patients because the hospitals just say, well, you know, they sell it to these companies or these.
Yeah.
And we'll just address that because
there would be no bills. This would be it will be all covered. Now, I'm glad you mentioned that because I had forgotten. I wanted to put in a plug for this company called RIP Medical Debt. I don't know if you've heard of it, but these folks started out as bill collectors and they had an epiphany and they said, you know what, this is a dirty business. So this company, RIP Medical Debt, buys medical debt for pennies on the dollar, and they're a 501c3. As they get charitable contributions, they forgive the debt. So, you know, and you can't apply to have your debt forgiven. They have a very complicated algorithm for who to do it, who to do this. But people will get a letter in the mail that says your $6,000 debt has been forgiven, and they target people with certain income levels, certain ranges above the federal poverty level, and they also have organizations in different states. They do have a Utah branch. So if you contribute to them, it's like I said, it's a tax deductible contribution. They will buy the medical debt of Utahns in a certain income range and forgive that debt. So, you know, rather than a debt collector making a profit, if they buy $100 of debt for $1, if they get $1 as a contribution, they can forgive that $100 of debt. So it's a good organization. I mean, we're trying to figure out a way that we might be able to work with them. But I also listened to that same NPR interview, and that's what made me think I should mention it today. They're really a Band-Aid on the system. The idea is not to have medical debt in the first place. And they admit that they're a Band-Aid, but they're doing a good job, in the time frame now. So it's a good organization.
I guess on the other aspect is the cost of a doctor going to school, and they have 6-figure debt, 7-figure debt sometimes. Is there a way for universities to help the doctors out there that don't have to carry?
Yeah, diminish their administrative loads.
Yeah.
Show the same graph as the one that you showed for universities.
Yeah.
I was teaching as some residents, and 2 of the residents, family practice residents, had over $500,000.
It's unbelievable.
Of debt.
Yeah.
It's crushing.
Yeah, it really is. And as you start unpeeling this onion, you realize that we need to go back to decrease costs of medical education, because there are physicians who are trapped, first of all, in specialties they may not want to practice in, because there are high-paying specialties and lower-paying specialties. And, people have to do what they have to do to pay off their debt. And there's no question that that's an issue. So as you start to work on this, you see there's all kinds of levels, medical school debt, then we get back to college debt. I mean, we're not going to be able to solve all those problems. We can work on a limited number of things, and there will be ripple effects from that. But there's no question that physician debt is an issue. But physician costs are small compared to, costs to the system are small compared to hospital costs and pharmaceutical costs. So,
you've probably read T.R. Reid's book.
It's on my nightstand.
Yeah. The thing that pops into my mind is the whole questioning of authority structures, and just kind of the entire way our civilization is set up by younger people who, many of whom that I speak with, don't have a doctor, don't
Yep.
see a doctor, don't want to take medications from big pharma. So I think, there's a wave coming, and it may actually render some of this discussion moot, honestly, in terms of recreating a healthcare system that is not a top-down authoritarian system where patients actually drive their own healthcare.
Yeah.
Rather than being, the notion that you go to see your doctor 2 or 3 times a year and he or she is able to intervene and help you craft a healthcare plan that's really going to be what you need is kind of silly.
It is.
When you think about it.
Yeah.
And I think that's what young people are seeing. They're seeing, I don't need this authoritarian person, and particularly in this age of information.
Yeah.
Where this egalitarianization in some ways that information is creating. I think some of these problems are going to be solved through other mechanisms.
Yeah. Yeah. Dylan.
So my understanding is that one of the big reasons, there are many, many reasons, but one of the big reasons that healthcare is so much more expensive in the United States is that our Medicare in particular does not negotiate for lower prices the way that natural health services do in other countries.
Right.
You touched on this a little bit, but would a state entity have much negotiating power? And would they have enough, do you think, to potentially help drive down some of those costs?
There's two issues. One's pharmaceuticals and one is hospital costs. pharmaceuticals had always been off limits, primarily because of the ban from Medicare negotiating with pharmaceuticals. Now that's been reversed. I think you may have seen the 10 drugs that are now the initial ones they're going to negotiate for. I mean, the industry's already lined up to try to defeat that, and we'll see how that goes. The second is hospital costs. And, the economic principle was that by hospitals, joining together, you could get economies of scale and costs would go down. We found the opposite to be true. As hospitals join together, they become monopolistic and costs go up. And that's particularly the case in Utah. We're looking at something called the Maryland model. So in 1970s, Maryland developed a rate-setting commission that has hospital administrators, physicians, consumer advocates, insurance industry people. They get together once a year and they set the rates for hospitals in Maryland. And it's not a fee-for-service rate, it's a global budgeting rate. And so Maryland has been extremely successful in controlling hospital costs over the last 30, 40 years. It's the only state in the country that has done this. But we would push to try to do something like that in Utah too, because hospital costs are really one of the biggest drivers of these expenses. But that's been studied extensively and has been found to be a legitimate model. The hospitals are making as much money as they need to make to stay in business. What they have done is they have found that it's cheaper for them not to have people in the hospital. Right now, hospitals all want to be full because that's how they make money, is by being full. In Maryland, their sort of byline is, we don't want to see you again. They want to discharge people from the hospital. They want to not have them come back. Well, to do that, they have to invest in community health things. They have to invest in preventative care. They have to invest in all the kinds of things that keep people out of the hospital. So rather than the financial incentive being having a full hospital, the financial incentive is, I've got this much money to spend this year on this hospital. This hospital needs to figure out a way to economically, treat the people that need to be treated, but don't admit people just because they're a profit center. Okay, well, thank you very much. I really appreciate the time, and please visit our website, sign up if you're interested to be on the mailing list. And if any of you would like to discuss this further, I'm happy to do it at any time. Thanks. Do I stop sharing? Is that it?
Oh, yeah. I'll replay.
I can stop sharing, I think. Did you get it back?
I'll get it back in just a second.
Okay.
All right, well, thank you so much, Dave, for joining us today and for talking to us about potential exciting solution to a very, very large problem. You are now invited to come forward to light a candle of hope, memory, or gratitude. You may also wish to drop a stone of burden or forgiveness in our sacred gathered waters. It can get crowded, but please form a lineup here to the center. Now for our offering today, I'll announce the offering once we're done with candles and stones, sorry. So we're gonna do candles and stones now, so please come up and light a candle or deposit a stone. All right, thank you, everybody. For our offering today, we'll be sharing the plate with Common Sense Healthcare for Utah. So anything you give will be split between them and our church. Now please join in calling for the offering. Oh, sorry. Now please stand, embody your voice, and facing the center aisle, sing together the offering song printed in your order of service. From you I receive, to you I give, together we share, and from this we live. From you I receive, to you I give, together we share, and from this we live. Thank you for giving. This money helps this church, helps us in our efforts to improve the world in big ways and small. All right. Now our closing hymn today, please stay standing as we sing our closing hymn. Our closing hymn today is number 1024 in your soft back teal hymnal, When the Spirit Says Do.
So what we'll do on the verses is first verse, you got to do, second verse, you got to work, and third verse, you got to shout. So do,
work, shout.
And then do again?
No. We're just gonna start shouting this time.
Okay.
Okay.
got to do when the Spirit says do. You've got to do when the Spirit says do. When the Spirit says do, you've got to do. Oh Lord, you've got to do when the Spirit says do. 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 You've got to serve when the Spirit says work. You've got to work when the Spirit says work. When the Spirit says work, you've got to work, oh Lord. You've got to work when the Spirit says work. 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 You sound when the Spirit says shout. You've got to shout when the Spirit says shout. When the Spirit says shout, you've got to shout, oh Lord. You've got to shout when the Spirit says shout. 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 All right. As the service comes to an end, please join me in saying the chalice extinguishing words in your order of service. We extinguish this chalice, but not the warmth of love, the light of truth, nor the energy of action. I thank you all for joining us today, and after our postlude, we'll meet for coffee and conversation across the parking lot.